Okay, good morning everyone, thank you for joining us. So today we have colleagues from within the department that are initiating a research study coming to present to us, and so it's wonderful because it gives all of us, some of us are aware of what our colleagues are doing because we're on a committee or other, but many of us maybe don't know what others are doing, so it's great. It allows us to connect with one another, seeing how we can support the new initiative, and perhaps the presenters have questions that we can help answer. So the format of these rounds are research in progress. The intent is to discuss and use your colleagues' expertise to be able to address some of the questions that you have. So it's informal, and so I heard somebody say, "Oh, we didn't know it was going to be such a big group." It's not. It's very informal. There's no official structure. So presentation, not too long. Ask your questions so there can be a dialogue. That's the intent. That's what we do when we present. Thank you. Oh yeah, I guess maybe Doug will tell us about.
Oh, sure. I'll do a little bit of housekeeping then, for sure. Okay, as I hope we have people off-site as well as on-site, for all our presenters this morning, yes, we could, when you're presenting, stick within the square here, the boundaries. That way you're going to be captured on camera, as well as your voice will be able to be projected to the microphone. So as Simone has indicated, we're back to sort of our true roots of research and progress. And it's my pleasure to be able to introduce actually many people that I've worked with, and so that's a pleasure for me. And our first two presenters that I'd like to present are Dr. Alison Eyre and Dr. Sarah Funnell. Dr. Alison Eyre is our esteemed Director of Postgraduate Education, and she has been since July of 2011. Her path to a career in medicine began at McGill University, where she received her medical degree, and then she went on to complete her residency here at University of Ottawa. And she currently practices at the Centertown Community Health Centre. Now, she brings with her a wealth of knowledge and experience acquired as a community physician in her role as IMG Director and through other teaching and development activities within the Department of Family Medicine. Dr. Eyre's vision of enhancing the department's profile and being a leader in family medicine education aligns well with the DFM's strategic plan and vision. Her activity, creative, and responsive leadership style will help us move the DFM towards achieving our academic goals and objectives. Dr. Sarah Funnell is a family physician working in Ottawa while completing a 5-year residency in public health and preventative medicine. She is of First Nations, Algonquin Mohawk descent, and graduated from the University of Ottawa's Aboriginal Medical Education Program in 2013. She continues to be actively involved in the program, mentoring and educating medical students. Dr. Funnell is the recipient of the College of Family Physicians of Canada's Medical Student Leadership Award 2013 and is chair of the Indigenous Health Working Group with the college. Most recently, she's been provided the keynote address. The keynote address at the University of Ottawa's Faculty of Medicine's Aboriginal Celebration for incoming first-year medical students, highlighting the importance of cultural safety. In addition, Dr. Funnell is participating in a working group with the Department of Family Medicine's developing Indigenous health curriculum. Dr. Funnell is a Master's of Epidemiology candidate at the University of Ottawa with a research interest in social determinants of health and ways to help improve health disparities.
She's my resident. I'm now feeling really
Please come on up and we look forward to your presentation.
Thanks, Doug. Can we both sit here, sir?
face down.
Oh, okay. No, you can say hands.
You can tell she does more media than I do. Thank you very, very much. They were in the slides. Okay, so we will try.
No, you're fine, I'll let you know if you're outside of the box.
Very complicated, the logistics here. Thank you very much for that introduction, Doug, and thank you very much to this group. We're really excited to present our research, and one of our other researchers, Toby Oatson from Pediatrics, is actually trying to find the building. So hopefully she will find the building. If Sarah has to grab a text again, that will be why. We're just going to jump right into this. Sarah's going to start with background.
So our project is called Identifying Our Most Vulnerable Children, and we're trying to develop a pediatric risk screening and communication tool that addresses the social determinants of health. So today's presentation, we're going to talk to you about the background of our project, our objectives, some methods, our planned analysis of the results, and hopefully engage in a discussion about some of our questions and get some advice from this group. So we all know that social factors predispose people to poor health, and there's been numerous socioeconomic determinants of health identified by Raphael and Marmot, but also the World Health Organization and the Public Health Agency of Canada. And as family physicians, we often use risk assessment tools for other things, like say cardiovascular risk and Framingham and other risk tools. But most of those don't include social or economic factors. So this was one of the impetuses for this group to come together and start working on this project.
Okay, the impetus also came very much from the ground up. A lot of the physicians, just came a lot. Community at Centertown, we work with a lot of vulnerable children and a lot of vulnerable populations, and there was a huge frustration felt with when we send our children into sort of more tertiary care centers. There was no way for people to understand that they may not have the supports of an average sort of middle-class person, that there were other factors that needed to be taken into account. And so at the same time, there was an identification within CHEO that those who were working with the very vulnerable populations within CHEO were finding the same things. When the children traveled throughout the tertiary care center and then back out into the community, there was also no way to flag the socioeconomic sort of specialties that might influence their care. At the time when we started this group, Dr. John Lyons was working at CHEO, and he's the one who's worked. He's actually from the states of North Carolina, but he's a leading researcher in the kind of tools that will allow the identification of other factors when you look at sort of the primary care principles going through in the care of someone. These kinds of tools have been used for seniors as well as children and in other populations. So with all this kind of energy coming from different directions, we formed the initial CANS PCI committee, where we just started talking about how could we work as community, tertiary care, doctors, social workers, admin, how could we come up with a way that would be, that would retain the dignity of everybody, because obviously these are difficult situations, but also allow, when the kid goes with a broken arm to the very, very busy orthopedic clinic, no, this isn't someone you can just hand an English document about what to do with cast care and have them go away. There may need to be something more there. So this committee has been meeting, and I'm going to just give you an introduction very quickly to who's on the prime grant. Myself and Sarah have already been introduced to. Toby Oatson is a pediatrician who works an enormous amount with vulnerable populations within CHEO. Toby's walking in right now. She's just rang the doorbell. She also runs a clinic at Centertown, looking at how we can bring within the community access to specialty services and still keep it embedded in the community and still have them be patients of Centertown but access the resources. Catherine Moreau is an assistant professor at the Faculty of Education, and we have enormously benefited by her guidance with methodology. Lindy Sampson has actually just moved on to a very big position at CHEO, so we're hoping we'll be able to benefit from her wonderful experience, but we know we won't get too much of her time. Janice Cohen is a staff psychologist who will be working with we mentioned John Lyons, I mentioned before. Lindsay James is one of the administrators at Centertown. And it's that sense that in order to really make this work, we need that balance within the team.
Okay. So as Dr. Eyre has described, our group is multidisciplinary. We have physicians, psychologists. In addition to that, we've been working with some social workers and some administrative people through Centertown and CHIO. And, you know, I was just sort of reiterating what Dr. Eyre has already said, and that the group came together for the shared need to communicate something that's really important that affects children's health care, and that's these social determinants that may not be explicit in a consult letter to a specialist at CHIO, or vice versa back to us. And our goal was to communicate this risk, the social and economic factors in a single risk score that could be used universally and that everybody understood. And with the ultimate goal is to tailor interventions for those pediatric patients that address their needs. So if as Dr. Eyre indicated, you know, at the CAS clinic, perhaps just a handout is not enough for patients that, say, don't speak English or are new to our healthcare system. And so it was very fortunate that the group met John Lyons, who was working at CHIO at the time. I think he's moved on since then, who's developed tools already that address these issues, primarily in mental health, and he's done some studies on the mental health tool. And so the CANS PCI group is what we're calling ourselves, but CANS PCI, CAN stands for Child and Adolescent Needs and Strengths Score, and PCI is the Pediatric Complexity Indicator. So it's a lot of words, and from here on we usually call it the tool or the risk score. And this is the tool that the group had refined in 2013 when I joined the group. And it has 8 domains, and they are scored on a score of 0 to 3. And the scoring's a bit complicated, but which is one of the reasons why we're still refining the tool, actually, because it's a bit long to fill out, although the one that we presented on the slide is a lot shorter than the original CANS PCI tool, which had very many domains and it took a long time to fill out. And the intent for what we're working on is a quick screening tool that can be used in primary care and or at specialty clinics, something that can be done very quickly. And so the predecessors to the tool that we're hoping to refine was not appropriate for that setting. So here's a timeline of what we've done so far. So as Dr. Eyre mentioned, the group formed in 2011 and came together to find ways to communicate socioeconomic risks in a way that everyone understood. And I joined the group in 2013 as part of my family medicine research project. And an initial draft of the tool had already been created when I joined the group. And so as part of my research project, I wanted to pose the question, is the tool measuring what we think it's measuring? So we ran a pre-pilot with some paper case scenarios and asked a few questions of the group. For example, we asked them to read the case and then rate it on a scale of 0 to 5 how complex they thought the case was, and then they used the CANS PCI tool, and then they were asked some questions about how well they thought that it matched up. They thought it matched up well to what their intuition told them about the case, but they did say that it was still quite lengthy to use, and so that made us rethink the project. We started to reframe this more as maybe a research endeavor, and as part of that, we started meeting with community groups and gathering information. And at one meeting with the community pediatrician, someone mentioned asked the question, how do patients and parents feel about being assessed in this way? And so that really enlightened us, enlightened me for sure. And we've already been starting to think before that comment that perhaps we need to engage the stakeholders, so parents and children that this tool is going to be used on. So to gather more information and see how they feel about being assessed in this manner. So so that brings us to today.
So basically, we've kind of given you the whole background. The goal really was of this project is to go back to the stakeholders and get a sense of how could this be used? Is it going to be measuring what we want to measure? So there's questions about are we revising a tool or are we going to rewrite a tool? And that's what we're going to talk about in a minute. Phase one is really about determining what items to include, and that's what's going to define whether we revise it or we start with the new. We start new, and then we'd like to be able to get a sense of how the physicians will understand and process and respond to using the tool. So the first phase is really where we're working with different focus groups with healthcare providers, adolescents, and as well with parents to really get a sense of using qualitative tools to get a sense of, in focus groups, what are the issues that are important to them, and also what are the issues that they would feel safe, particularly in the adolescents and parents, that they would feel safe having communicated by this by this tool. The analysis, we will use the conventional qualitative content analysis, reading the transcripts, identifying the items, triangulating to find various, triangulating the information from the various focus groups, and developing a draft tool. And that's where it'll be, where we say, is this a draft tool? Were we able to use anything from the CANS PCI? There are other tools we've looked at, but most of them more sort of talk about vulnerability and risk. They don't necessarily bring in the factors. So we'll look at that information with the background of of what's in the literature already. And then the phase two.
So our intent is that after we've revised a tool, we're going to then do some response process evidence with physicians, or it could even be social workers or nurses, anybody that works with this population. And the intent is to get physicians from, or other clinicians from both the population that we serve and a standard population that maybe doesn't serve as many vulnerable patients. We'll ask them to undergo cognitive interviewing with a research assistant, and they will complete the tool and participate in this cognitive interviewing. So the idea is that each physician will complete the tool twice after seeing 2 patients. So they'll see a high-risk patient, and they'll see a patient that they think maybe isn't as high risk in terms of their social determinants of health. After they see a patient, they will meet with their research assistant and undergo cognitive interviewing. And so the plan is to identify potential problems. So is there comprehension issues with the tool, something that's not clear? Any bias problems, we'll say the tool is indicating that they should rate it in a certain way. And then how they respond to the tool and each item. So the idea is that to interview each physician after they use a tool twice, and then to identify item by item their responses, and then to compare it across all the physicians to see if there's consistencies or inconsistencies. An item that has lots of inconsistencies, where people are responding all over the place or don't understand the question, those are the items that we have to consider whether or not we want to include them or refine them. Some items perhaps are very closely asking the same question, and maybe we don't need to ask those 2 things that are addressing the same issue. So that is the intent of the cognitive interviewing.
Before I go on to dissemination, I just want to say, I don't know how many of you guys use tools in your day-to-day practice. You think, where did this question come from? I have no idea how to answer it. I know I feel that quite often in my day, and I think one of the reasons we're starting there is because this tool is in such a delicate area, because it's dealing with such delicate information within vulnerable people. It's also going to be used by very busy practitioners. So you have 2 big risk factors And that's why we really want to go and understand the thought process. How do people, I might write a word and see it one way and have no idea why Sarah would see it totally differently. So that's the purpose for taking so much time and energy, the delicate population as well as the very busy people who are going to use it. Dissemination, so we actually, with the pilot, are hoping, to get a lot of people involved and sort of work with this in many ways, bring people in and implement it widely, but in terms of presenting it and disseminating it in terms of a more of an academic and research way, we hope to be able to present at the annual Family Medicine Forum and possibly pediatric meetings that are appropriate in the area. So, I think, sorry, we took longer than we were supposed to. I think our real questions to you are, does this sound reasonable? I know we've described sort of the methods we're going to use in the research. Are we asking the wrong questions? Well,
I can't help myself. So you made a very important question right at the last, which I think you haven't used the word feasibility yet. Mm. And I think one of the things that pops into my mind is feasibility, yet another tool. And where you may get some, I think you need to stay at phase 1 because, you're going way ahead, but at phase 1, you're going to look at some of the feasibility questions. You're very worried about safety, but there's also about utility. Mm-hmm. And the big issue here is, in my mind, is 2 questions that will pop out. One is, what are you going to do with the information? Mm-hmm. The other one is it appropriate for the physician to be filling this out? Maybe the tool is more appropriate for the person presenting to be filling it out, or having another healthcare professional involved that's less threatening. Because your feasibility question of busy practitioners, this is very physician-centered. The physician needs to do it. Let's think something else.
Excellent comments, thank you.
Yeah, I echo what Diane says, and what I was thinking as you were going through it. So I think it's highly, a really very important topic, but I was thinking about the parallels between the PHQ-2 and the PHQ-9, and you may find some interesting literature in terms of that, and that's, well validated. We have it on our computer screens and all of that, but from a very practical point of view of implementing that in our clinic, systematically, it's been very challenging exactly for the reasons that Diane brought up. And that one on the, the PHQ-9, you think it's, for those of you who don't know, it's 2-question screening for depression, really easy to just ask, and then if it's positive, you go on to 9 questions. Well, when you go on to the 9 questions, then it has a suicide question, and we tried to download it or whatever, share it amongst the team. Nursing didn't want to ask people whether or not they were suicidal, because then there was a whole then I have to act on it. So that's the sort of, so I think if you sort of take it, when you're looking at feasibility, I agree with Diane, I would look at that right away. And then, but there will be parallels, and to me the best parallel would be, what's all the literature on the depression screening tool.
Excellent suggestion, thank you.
Oh, Toby, you want to answer that? Toby's here.
You had quite excellent comments and quite extensive discussions around this. And so one of the things that we have that we're hoping to do in the phase 1 piece is look at the difficulty, many of the existing sort of quality of life resilience metric scores that we looked at, similar, that don't have the same, the domains for the PANS include the biological, the psychological, and that's why we're choosing to try and create items to map onto the existing PANS domains, because we think they're probably out of the existing tools. But the quality of life ones, there's a number of different child and youth resiliency metrics for one that are parent or provider reports. The difficulty is who has more time if the parent doesn't have literacy, or the parent, if the parent isn't literate, the parent doesn't have the language of the tool, then that creates another sort of barrier. So what we were hoping to do was when we do our second phase, we're going to have some folks that aren't doctors try it. So the idea would be the tool wouldn't have to be implemented necessarily by the physician. There could be other care providers that would do the tool, and then also to include a parent rating item. But we've decided and that's one of the things we want to explore with them in the initial questions in terms of asking the families how they would feel about someone else rating, because we had very extensive circular conversations about what's actually faster, hiring somebody to sit with the person and help them complete the tool in every setting if you want it to be a quick 5-minute screen, or is it faster to have whatever clinician is with them, it could be nurse, social worker, physician, fill it out, but to have a single parent self-rating question that you can ask, any care provider can ask them to do that piece to try and capture their impression of their own situation, which is hugely important. But that's some of the issues that you can see we've been circling with this for a long time, and that's some of the issues we've been trying to sort of, and we're hoping that if we can start with the initial content domains and then have the focus group with our stakeholders, that we can maybe get a little bit of clarity. But of course, then the huge importance of phase 2, because we may completely fall down in the part 2 when we do the cognitive interviewing. People may tell us, you know what, this is just like not at all feasible. But in terms of having a place to, I'm sorry, I know we're short on time, place to move forward from it, you know, appreciate further thoughts or comments on that, because we have struggled with that. And that's where the actual existing CANS tools and child and youth resilience doing enter these other longer ones fall down. There's all of these great sort of indexes, but they can't get completed in your typical busy practice setting. They have to be in an enhanced care setting. So how do we get people to that enhanced care setting? Like, how can we screen them quickly to identify they need to be in a place where they can get extra help? Yeah.
Gary?
So, you know, I have a whole bunch of mixed thoughts running through my mind as I listen to this. And I have to say that, you know, I don't work with vulnerable populations particularly, though obviously I have vulnerable patients over the years. I don't work in a community health center. But my first thought is I worry about that this may actually paradoxically harm people because you stigmatize them. So that's the first thought that runs through my mind. But the second issue is, as a family doctor, I see a vulnerable patient, I know they're vulnerable. I don't need a score to tell me that. I can understand it would be valuable in transitions because that's important, but aren't we supposed to be educating people? That's what the health advocacy role is all about in the specialties, to be understanding and communicating with their patients appropriately. So I just am wondering where this fits.
So Barry, you just summed up all of our discussions. It's because from the community health centers, I send things into CHIO, I write everything, not CHIO, but anywhere, I write everything about the vulnerabilities, and I get back something that's just not feasible for that person in that environment. So this is totally about transitions, and it's totally about kind of come up with a language where someone doesn't have to read an entire huge long consult note, which I'm sure every consultant reads every note word by word, but actually I think a lot of them go for the crux of what they can get. And the idea is, how can we transfer? It is about transitions, but the whole thing that spurred this research on further and wanting to go back to these groups is that sense that we don't want to stigmatize. We know that the transitions is where people lose the complexity in their services, but we also know that for privacy reasons they may be willing to accept that loss.
Yeah, so that was a big issue and eye-opener when we started those discussions, and so this is why we're here today instead of where we were a couple of years ago trying to pilot the tool in the clinical setting. We wanted to step back and speak to the stakeholders and ask them, how do you feel about being rated like this? Yeah.
So I want to validate what you're doing, because we were doing a study where we have to identify people's social barriers so that we can help them overcome these barriers, and those tools are not there. There aren't the quick, and you know the physicians in a busy practice is not going to answer 25 questions to understand whether poverty or whether behavior is a problem. So I think there is definitely the need for this. And you know the poverty tool, where there's one question that you can ask that's actually going to identify financial barriers. So we need those tools. They're not out there. They're really important. What I'm wondering is, if you're thinking about the purpose of the tool is to make sure that the individual gets the support that they need, and that they're not sort of prescribed an approach that's kind of beyond what they can do, why do you need a score? I'm wondering about, you've identified dimensions that are important. I think Gary's right. I think, that patient is complex. We know it. Do we need a number? I would say no, but perhaps we need to identify what the complexities are, and that's really what it's about. Yes, you scored high, physical barriers, emotional barriers, that's all you want, as opposed to making it into an overall score. Some thought.
Just so much into all of the discussions we've had, going back and forth. I'm not sure, and that's why we're asking the question.
I think
Yeah, I think there'd be tons of opportunities for one, but I think we're 20, have we gone over?
Yeah, you've gone over 1 minute.
So I think we need to move on. Just in fairness, let's chat at the break.
Yeah.
So we'll need to move on to the next.
So Alison does have to leave.
I'm going to say very rudely, I do have to leave.
Maybe Claire can jump out and give Alison some advice before she goes, but.
I will say.
It's my pleasure now to introduce Dr. Chuck Adamson, who graduated from the University of Ottawa in 1977 and completed his family residency at the University area from 79 to 2014. And while there, held many senior administrative positions at the Winchester District Memorial Hospital, including being Chief of Staff. Since 2015, he's been working full-time with the Bruyère Academic Family Health Team. Dr. Adamson has been a preceptor for many years and has had a great interest in meditation since the early 1990s, and from which stems his application for his Prime Grant and method to improve resilience and compassion in family medicine residents. So without further ado, here's Chuck.
Thank you very much. I appreciate the opportunity to come and speak to you today. I was introduced to meditation back in the early 1990s by our parish priest who held a session of introductory meditation on a weekly basis in my office waiting room, because in rural parish they only keep the church on Sunday. So anyway, we used the meditation come up with by a guy named John Main, who was the guy who was exposed to meditation while working for the British Foreign Service in Kuala Lumpur, and eventually became a Benedictine monk and started a monastery in Montreal and held a series of public lectures on meditation. So surprisingly, after learning meditation, I used it quite a bit in my own existence, with dealing with stress with practice, and also in trying to get focused when dealing with complex patient issues. I did teach to a few patients who also found it helpful. How do I get this? There we go. It's interesting that empathy scores have been found to go down through medical school, and that there's a high degree of burnout and depression in medical students and residents. Some studies show as much as 75% of residents may be suffering from signs of burnout, depending on which specialty. And of course, doctors report symptoms of burnout also report a higher risk of medical error. Resilience is defined as the ability to recover readily from illness, depression, adversity, or the like, and empathy is the experience of understanding another person's condition from their perspective. So you place yourself in their shoes and feel what they're feeling. Empathy is known to increase pro-social or helping behaviors. So meditation has been practiced using breathing and mantras for a number of centuries in different religious traditions, and of course John Kabat-Zinn has made it very much popular with his mindfulness-based stress reduction courses, which are 8-week courses where there's a 2.5-hour class session per week, and people are asked to meditate for about 45 minutes at home. And with that, they found quite significant improvements in physical and emotional problems. A guy named Andrew Newberg has done a fair bit of work with functional MRI scanning, where you can see what part of the brain is activated when you're doing certain things. And they found that when people meditated using a mantra and a mudra, such as tapping their fingers together, it reduces the activity in the limbic system, where your fight and flight response is, and increases the activity in your anterior cingulate, your prefrontal cortex, and these are areas associated with emotional regulation, learning, memory, and enhanced social awareness. In one experiment, for 8 weeks, he had an industrial mechanic who was concerned he was losing his memory, do a meditation for about 12 minutes a day, and he was able to demonstrate a 50% improvement in his memory scores after 8 weeks of 12 minutes per day. So since he was improving his memory, which is using the same area of the brain, my thought would be that 12 minutes a day may also improve social awareness and decrease anxiety. In 2007, there was a web-based survey of 74 faculty members and residents showing a high interest in relaxation techniques and meditation. Mindfulness studies conducted with medical students using 75 minutes a week with a class time with the half-day retreat at the end did show some benefits in this same area. Residents have very little time to spare, and so my question is, would a 12-minute meditation per day be enough to make a difference? So that's the research question. The population we would choose would be PGY1 and PGY2 family medicine residents. The intervention would be 12 minutes a day of meditation consisting of focused breathing, a mantra, and a mudra. We could have a comparison group of other residents who didn't do the meditation, and the outcome would be a change in scores and standardized tests for empathy and resilience. The purpose would be to assess the feasibility, acceptability of a 7-week intervention of brief episodic meditation, and we measure the effects of this intervention with these scales. Pretty much saying the same thing there. We would have no exclusion by resident characteristics. The residents would be recruited by both a paper and email invitation to a lunch and learn session, and we would hope to have about 10 residents participate in the study. The residents would be asked to download an app for their phone, which would remind them to meditate. They would be contacted every 2 weeks by a research assistant who would troubleshoot and motivate, and they would attend to lunch and learn. So that's sort of the chart showing that. The beginning session, they'd be taught the background and how to do the meditation. They would be administered a demographic survey, seeing what their initial meditation experience would be. I chose 2 scales. One is a Jefferson Physician Empathy Survey, Student Edition. The reason for that was that people questioned whether a self-report would be sufficient, and there was one study that showed that the results of this compared favorably with the observations by practice patients in an OSCE setting. Their scores of what the students' empathy was would compare very favorably. The Connor-Davidson Resilience Scale has been used in the medical student rating over a number of countries. In fact, they have actually 3 versions, a 25 question version, a 10, and a 2. And the 10 has been validated to be just as good as the other ones. So data collection, demographic survey, including questions involving current medication practices. The Jefferson is a 20 Likert type item scale with a 7-point scale, and the Connor risk is a 10 item scale. The outcome, we would look for the feasibility, acceptability amongst the residents, and that would be determined through focus group discussions and phone calls by the research assistant. Empathy would be measured with a scale of the Jefferson Empathy Scale, and resilience with the Connor-Davidson. Because the pilot study, we're more concerned with the acceptability and feasibility than the actual power, whether you can get some actual results because of the small sample size. The results would be presented within the department, maybe at these rounds. We would perhaps create an abstract, be submitted to FMF, and we would share the results with the Resiliency Committee and with residents. The questions that your prime committee came up with was there was concern about coercion if the residents were only recruited from my site. And the concern was the small sample size, and the concern was that if we didn't have a control group, which we initially didn't, whether there would be some other factor in the new environment which could have an equal contribution. So some solutions suggested would be to have a co-investigator to do some more research to find whether there's a better methodology in answering the research question. and whether to offer such a session prior to actually have an actual study. So it's a simple meditation. You sit down in the chair and you get in a comfortable position and you focus on your breathing. You breathe in and you breathe out. A mantra is a word of significance. You say half the words you breathe out, you say half the words you breathe in. And you just do that. And most of our brains are going a mile a minute, and then you say, you do that for about 5 seconds and your brain's off running again. Say, oh yeah, I'm supposed to be saying that mantra, I'm supposed to be breathing. So that brings you back to it. And interestingly, there's been a lot of work, I think, called the default mode network, that they did functional MRI scan and had people look at a crosshair, and they found that when they were just kind of daydreaming, certain parts of the brain lit up, and activation of those parts of the brain have been associated with more rumination, which has been associated with more depression. And when you do this simple mantra and breathing thing, you turn that off. So, often I'm sure as physicians we always second guess all the stuff we do, and you can go down a long road of beating yourself up, and doing meditation turns that off. So it's a really good way to stop those things. That's my project. I'm open to any suggestions people may have.
I've always had questions. It's very interesting. I think there is good research out there that this is helpful. So I guess one of the things is what's new and different about what you're doing. There's a fellow at Monash, Craig Hassad, who's done this with medical students. I think we know Milleray is doing it here with medical students. So I guess the big question here is, when I listen to this, it's acceptability, I guess, is what you're worried about here. Is that, and the other thing is it possible to do a sham intervention?
Yeah, so they have done ones where people just do relaxation techniques as opposed to meditating. So the meditation has been out of some of those. I guess the other question I have is whether the time frame is what I was looking at. The main thing that the MRS, whatever it's called, is 45 minutes a day. This is 10. I had mentioned that there was a study in certified practical nurses where they did it for 10 minutes a day, and they found the results equivalent to the 45-minute session. So yeah, so whether residents would be willing to buy into this, and whether a short time would be as good as the standardized 45 minutes a day.
Just a question of clarification. The 10 minutes was broken down into...
Yeah, I initially did that. That was my initial thing. And then I did actually set the app to do that 4 times a day. And after doing it for a while, I realized most of those 4 times I was busy doing something else. And in fact, it worked better to have 12 minutes in the evening or whatever when you weren't distracted. So my initial...
Okay, thanks. Just wanted to clarify.
Oh yeah, so just to share with everybody, so I saw Chuck, I guess, talk about this maybe 6 months ago, and I would congratulate you in terms of how actually, I know how much work you've done and how you actually have brought it together so succinctly. So just there's been a lot, I know you've done a lot of work on this in the background, and it's really, really progressed. So I think in terms of then sort of your issues, so I think it comes down to what Diane was saying. You just need to decide on what the question is, and the new question, I would agree, is basically the acceptability and the feasibility of whether or not a resident can actually do this over 7 weeks, do the meditation, and then, and then the other piece is you're in a sense testing the scales. But so I would argue actually, or I would agree that you do not need, I don't think you need a control group. You're not going to do that. Running it with 10 people and focusing and keeping it just on that, where this is about, can you actually implement this? Will people sign up? Will they come to it? How many days are they going to actually manage to do it? All of those questions are really about the feasibility of implementing this actual approach. And that's a very valid, basically, question to ask. And the answer, if you then get the answer which then looks really positive, there's some trend that this is good, then that's when I would, encourage you, depending on that, to go bigger. So that would be, I'm not sure if other researchers agree with that.
The other question I have is contextual, because, our residents go through a variety of different experiences as they're going through the residency. And there are some that are calmer, easier to be able to participate, others that are less easy. And when they're busier, they might need it more, but they're less likely to do it. So I'm not sure how you actually determine acceptability with only 10. Because I mean, if they're all in the same sort of environment, you're only testing that environment. If they're all in different environments, you don't have enough information.
I guess the point is, if you can get some buy-in from a small group of residents, they may spread it to other ones, saying, yeah, we tried this and it actually worked. I mean, I think it would be much more saleable coming from other residents than would coming from me. So part of the purpose of doing research is just to set the seed for further stuff.
But I guess what Gary is saying is that, so there's going to be variability, so some folks might find, so are you going to be able to tease that out to sort of understand? So if some folks are saying, oh, this was just not feasible for me, well, maybe it's because you're in a difficult rotation. So are you going to have, is 10 residents going to be enough? And so I'm going to build on what he's saying and take a look at not just the feasibility, but the outcome. So the effectiveness outcome, which you are measuring. So I know this is, principle is feasibility, acceptability, but you are measuring the outcomes. And, over such a, short period of time, when you could be in a difficult rotation, you might actually see like a drop in so what were the other measures, empathy or resilience, just because of the contextual factors, right? And with 10, that's going to be, and you really don't want to, even if you demonstrate acceptability and feasibility, if you don't show that you're not dropping the resilience, then it's going to be a hard sell. And with 10, you're not going to have enough to say, well, these guys didn't do well because, whereas these guys, those who, so it's going to be difficult to tease out because there's so much variability in their context. And chances are you're going to have some success and some that are not going to be successful.
But hopefully some of the narrative will say even people with bad rotation might find it a little bit helpful. Yeah, I appreciate that.
Yeah.
So would you not measure effectiveness?
No, I would. I'd have more people. I don't think 10 is, just to be able to understand a little bit the context.
So one of the things you might consider is thinking about choosing different time points.
Okay.
So having more than one group.
Okay.
So extend this longitudinally, but say, I'm going to take a first year group right at the beginning and test them, but then I'm going to take another group at a different time. Because some of this can be convenient sampling, right? It's easier to get them when they're in unit than when they're out of unit. But if you offer it over a number of times and then look at the different characteristics of their context and where it came in their training, you might be able to start to tease some of that out and build your numbers.
Could you partner with another group too? Like I'm just thinking with somebody else in another...
Because it's not an intensive intervention.
But outside of family medicine. There may be another specialty service who's interested.
There's a study going on right now in the undergrad with medical students, and that is done longitudinally. Miller is involved in that. It's Heather McLean who's running that one, and it's interesting. You're using both the resilience scale, the Connor-Davidson, and the Jefferson empathy. And I mean, some findings are what you kind of expect. But then there's some others that are a little surprising, and empathy is one of them. So yeah, I mean, they have larger numbers, right? And so maybe you could possibly team up with them, but I mean, then it's a different group. But I think teasing out, what we've said here, teasing out those difficult rotations, in the qualitative piece would be important.
Yeah.
I think it's a lovely project, and I know that there's evidence already that mindfulness for healthcare practitioners not only makes them more empathetic, but also makes them better healthcare practitioners. And I'm wondering if we can incorporate any qualitative assessment of resident performance in this. And I also see that there's really an opportunity to bring mindfulness to the department. And I think mindfulness, I'm a sort of an integrated medicine guy, and mindfulness is kind of the gateway drug for that whole field, because everyone buys into the role that mindfulness can play. in so many things. So it may be that just doing this, this first study will generate interest in mindfulness within the department and could lead to a bigger study that may involve more residents and some staff, and looking at how that would change the dynamic of the learning environment.
Thank you.
You have, like, so when you're talking about these sort of feasibility and acceptability, so do you have plans in order to log that? So what everyone's talking about, the context and what the environment, so where are they, when are they, what the season is, what's going on in terms of just local context, that I think that a lot of those things may come into play, and if you don't sort of plan to systematically capture that, it's hard to reflect back when you're doing your analysis a year later, perhaps, to remember what was sort of the nuances of the context. So,
great.
Yeah, you know, the big thrust in research now is like, people are not talking less in my environment so much about outcomes, effectiveness and all that, but context, just, okay, tell me about outcome, but tell me about the context even more, because it's all about context. So I think we're realizing in the field of research how much context influences, and so just want to reinforce all the comments around context.
Thank you.
The other question that I actually wonder about is, I don't know how the residents perceive the notion in the first place. So how many actually will volunteer to participate? I don't know, for example, in the medical school context, how many of the medical students are actually willing to participate in OA, and is that not a self-selected group? And is that, so I don't know enough about the people who choose to participate as being reflective of the majority of the residents. And I have no idea about that information.
I think you would expect them to be different, and I think that would be fine, because you would just recognize that. You know, when you do a randomized controlled trial, then you take a look who you're inviting, who's declined, and is it generalizable, which is what you're getting at. But at this point, whenever you're trying kind of something new, you do pick the best population, and so those are people who are going to volunteer. So you're right in that you're not going to be able to generalize, but I think it's a reasonable sample to begin looking at an approach.
Yes.
Well, it's using as transferability.
Yes.
So given the same context, similar people, thinking in the same way, this could be transferred to that similar population, but not generalized.
So I'm probably the type of resident that would be keen on your project. So I did a mindfulness-based stress reduction program at TOH for residents and really enjoyed it. In terms of feasibility, we did have some homework to do, and often I admit I didn't do it. But I think incentives really help, and that was part of it. So we did have a half-day retreat, and that was the big incentive at the end of it.
Just a comment and question from Dr. Lee's Eyre. She is saying, are you still looking for co-investigators? If so, I might be able to contribute more specifically from the methodological perspective. And she's happy to chat more. She's sorry she couldn't be here today, but she's online.
Great, thank you.
Contact her.
Please all help I get. Thank you.
Here, so well surrounded with lots of help in your clinic as well.
That's a great project.
I think what you're hearing is exactly that. I think what you're hearing is people saying, oh, absolutely, we believe it, we want it. And so people just want to contribute to make sure that we're going to have the strongest outcome. So I think you're well surrounded with, Claire and Lise and Claire, who's also been part of it. So